speakers. I'd just like us all to take a moment to recognize and acknowledge that we are joining this meeting today from either Dalhousie or Halifax or areas surrounding that are all located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kma'ki people, and that we are all tree people. And so just to take a moment to acknowledge that before we begin. And also to mention that we would like to record our session today and hope that people are willing and able for okay for us to do so. Again, welcome everyone to our Center for Transformative Nursing and Health Research. Our Wednesdays at noon, I am Dr. Marcia Campbell-Yo, the acting director of the center, and I'm thrilled today to have two sessions. The first presented by Molly Ryan, Lisa Albrecht, and Eva Ta, making sense of pediatric death, an exploratory qualitative study of emotion management strategies applied by the pediatric intensive care interprofessional team. And the second by Neda Akbari Nassaji, who is a PhD student exploring the health needs of immigrant women during the postpartum period. Without further ado, welcome everyone, and we'll start the first session. And I think, Molly, you have rights to share. Excellent. Fantastic. That looks great.
Okay, excellent. Great. So we'll dive right in then. So I'm Molly. It's nice to meet you all. I'm the principal investigator for this study. Thank you, Marcia, for introducing. I'll let Lisa introduce herself.
Hi, my name is Lisa Albrecht. I'm the research coordinator at CHIO in Ottawa. Thank you for having us.
And I guess I should mention too, my main role right now, I'm a research coordinator at the IWK in Halifax as well. And Eva is also a research coordinator who's at Sick Kids, and she's just running a few minutes late with some consent back at their site. So she'll hop on when she's done with that. And we're really excited to speak to you all today about our study. So let's see here in terms of our agenda. So we'll be going over our background and study design. Then we'll tell you a bit about where our project's at right now and our current status. Share some tentative emerging findings. And then we'll wrap up and talk about where we're going in terms of looking forward and our knowledge translation strategy. So first, as research staff versus holding faculty positions, we are funded in a unique way that we wanted to take a second to share with you all in case there's similar opportunities in your field. So we all belong to the Canadian Critical Care Trials Group, which is an open membership group that promotes and assists in the implementation of investigator-initiated and patient-focused multi-center research. So members include healthcare professionals practicing in critical care, researchers, patient and family partners across Canada. And part of that group is a Canadian Critical Care Research Coordinators Group, to which we all belong. This has been around since 2004. And it's a great way for people working in ICUs and pediatric ICUs across Canada to connect and share resources. And one exciting thing about this is every year, I believe it's up to 2 now, they sponsor research grants for research projects led by research coordinators. So it's a little background about how we came to be able to lead this project and do some exciting work, and we're excited to share more about that today. So as its own slide. So again, they support research activities of CCTG affiliated research coordinators, and now it's up to 4 grants per year for studies directly related to critical care practice. To jump right into what our study is about, we're running a qualitative study, and qualitative studies are typically interested in learning more about people's lived experiences. Our point of departure is, what's it like to work in the pediatric ICU where most pediatric hospital deaths occur? There's a lot of ways to approach that big question. We're interested in the emotional impacts of this, with this study asking, how do pediatric ICU healthcare professionals manage their feelings about death in the workplace? To answer this question, we're looking at things like how they manage their emotions in this context, how they learn to manage them that way, and what value judgments they assign to certain emotions. So for example, are there ways they think they should or shouldn't feel in this context? Through this study, we aim to better understand how the team manages their emotions when encountering death in the workplace. And our key objectives are to identify the specific ways in which they manage their emotions, to identify existing supports when it comes to PICU deaths and areas for improvement, and to explore any similarities or differences that come up between professions. A little bit about our theoretical foundation. So, emotional labor is a sociological theory about emotional expectations at work, or as it's worded here, it's the need to manage your emotions in order to perform your job. The classical empirical study on this was with flight attendants. So for example, an airline expecting flight attendants to remain calm or smile even if someone's yelling at them. Here's some different aspects related to emotional labor and its potential outcomes. This is just to highlight that emotional labor isn't inherently positive or negative, and we're not here to evaluate that. We're interested in knowing instead what it looks like for the PICU team. And understanding this experience is important because just like any other labor, it has the potential to cause damage if you aren't properly equipped for it. Two key concepts I want to highlight within this broader theoretical foundation are feeling rules. So the first one's feeling rules, which is really just emotional expectations, whether they come directly, explicitly from an employer or implicitly through workplace culture. On the slide, we have an example from a study with PICU nurses, where an interviewee said, "A few tears are fine, but too many tears cross an invisible line." This is also a great example of how these more implicit expectations can be made explicit through interview studies, such as ours. And emotion management strategies are the specific ways that people meet a given feeling rule. For the above quote, for example, the strategy could be stifling the emotional response in the moment and going to the bathroom later to cry. And I'll pass it off.
Thanks so much, Molly. Apologies for my camera. And so essentially, why does this all matter? Um, I wanted to introduce you to the word emotional dissonance. And so this is where, sorry, Molly, if you don't mind just clicking, thank you. This is where your expected emotion clashes with your true emotion, what you feel. So for example, you're in a room where you're feeling really, really sad, but you are holding back your tears and you're trying to remain calm and professional in the face of families that you're trying to treat. All of this emotional dissonance and excessive emotional labor can lead to burnout. And we know that burnout itself leads to increased error rates, lower empathy, quality of care, creates intraprofessional and interpersonal conflicts or substance abuse. And this can be seen, especially through COVID, where nearly half of the ICU intensivists display a high level of burnout. And in a 2020 survey of 225 Canadian critical care physicians, moderate and high moral distress, burnout, and compassion fatigue was reported. And particularly alarming is that a third of these respondents considered leaving their positions or the field altogether, and they were trainees. And so essentially, we have to make implicit these implicit unspoken rules to become more explicit so that we can reduce the isolation for those still learning to cope with death in the ICU. So what we know so far is that there are plenty of studies that show the effect of burnout and emotional labor. In a field isn't new. In fact, it was highlighted since the pandemic has started. However, a lot of these studies do focus on different methodology. So it's really difficult to compare whether or not these studies are speaking the same thing or finding the same effects across the different professions. Speaking of professions, we also know that the PICU is extremely multidisciplinary, and many of these studies have focused specifically on nurses. And so we wanted to explore and see how this topic of emotional management in pediatric death affects other professions as well, because everybody has a different role in the ICU. For example, in other studies that we found that we've read, respiratory therapists have reported more intense grief compared to nurses or physicians. And these studies that are not on nurses or doctors are mostly recent, but not peer-reviewed and published. So in our study, intentionally addressing these multiple professions in one single study, we can better identify, compare, and contrast emotional management strategies in the PICU as a whole.
So just to talk a little bit about how we're actually conducting this study, we're focusing on primarily full-time English-speaking healthcare professionals who work at any Canadian PICU. We're trying to aim for at least 2 participants per profession, just to account for any variability there, with a maximum of 15. Just of note, as Eva mentioned, there's a lot of literature on nurses, so we're making sure that we include at least 2 nurses so that we can confirm that our findings are consistent with what's published, sort of a double check. Sorry if you can hear my birds in the background there. The way we're recruiting these participants is primarily through networks like the CCC RCG, as well as our own professional hospital networks and the CCCTG. We sent out an email template inviting participants or potential participants to give us some information through a REDCap form. So the REDCap is requesting consent to store information and contact so that we can follow up with interviewees later. It's asking demographic details, for instance, self-identification as a person who is Black, Indigenous, or a person of color, a specific PICU role, and that allows for a purposive sampling to really get that maximum variation. We've been contacting people who fill out the survey to schedule an interview, again, based on that purposive sampling. And we're also using snowball sampling just to try to target certain areas. So looking at the next slide.
Yep, so I'll talk a little bit about our methods. So we chose a semi-structured interview design because it means that everyone gets asked a standard set of questions, making it easier to find patterns and make comparisons, while maintaining enough flexibility to follow the thread of conversation and probe as things come up organically. The methodological assumption here is that as researchers, we can't predict everything that might be meaningful or relevant for interviewees. So it's important to allow enough flexibility to ensure that those ideas can still be explored and included. Animation had a pause there. So our interviews are all transcribed, and we give all our participants the option to receive their de-identified transcript. This helps support transparency between study staff and participants regarding what's being analyzed and gives them an opportunity for ongoing consent if they wish to withdraw, no questions asked. Analysis, we're doing a thematic analysis. We'll independently, inductively code the interviews to identify key patterns and themes. Once we reach consensus, we'll be sending a summary of preliminary themes to interviewees who've expressed an interest in seeing those as a way to member check and ensure that these resonate with them, or to see if there's crucial aspects they feel that we've missed that we can then include prior to any formal knowledge translation.
We started contacting respondents through that REDCap form on November 16th, and we conducted our first interview on January 4th. So things have been progressing very quickly. We've got 60 volunteers for interviews, so 60 intake forms completed, and we're about halfway through with 7 completed and an additional 1 booked. Would you mind going to the next slide? We've gotten a range of respondents, and we've contacted physicians, child life specialists, RTs, nurses, and physiotherapists, although we've not yet completed our physiotherapist or social worker interview. We've also gotten interest in participation from pharmacists, clinical externs, and music therapists, although one challenge that we've seen in some of the less common roles or roles that less commonly experience pediatric death firsthand is finding that 2 people who are willing to participate, which, if you remember, was one of our criteria. Nursing has been the most prevalent role among people who have completed the intake form and expressed an interest in being interviewed. And we've gotten a large range in experience of our interviewees between 3 and 35 years of practice. To date, we've interviewed participants from these 4 provinces, and most of those who have completed an intake form are from Ontario, with Alberta as a close second. At this point, we're starting to have some direction in our purpose of sampling. We're looking for interviewees who may have a little bit less experience. So for instance, in that 1 to 4 year range, physiotherapists and social workers, people who work in the prairies or the Maritimes. We don't expect anyone to meet all of those criteria, although it'd be great if they did. But that's who we're looking for the second half of our interviews.
Great, thank you, Lisa. So before we jump right into our findings, I'm going to provide a few caveats or grains of salt. No, if my grains of salt will show up. So since we're very early on in our analysis and we're only about halfway through data collection, it means our findings could change significantly in framing once we are able to take them into the full context of all interviews. What I'm sharing today might be particularly important to our early interviewees, but may not be the most important findings from the full study. It's really too soon to say. That said, we did want to take the time to share some of these findings with the group and give you all a general idea of some of the things that we've been hearing so far. So one of the strengths of our study is being able to talk to a breadth of PICU team members who have different professional roles and responsibilities when it comes to end-of-life care. I have a quote here from a respiratory therapist where they say, "Nobody tells you the part where you're going to be the Grim Reaper one day." This is in terms of the RT role, where they're generally the ones who would be removing life support. So they have a very intimate, physical, professional relationship with death in the PICU that might differ from some of their colleagues. So I thought this was a great quote to provide a bit of context as we go forward. Interviewees talked about was the importance of recognition and feeling seen. So from a child life specialist, we hear, "What I find really hard sometimes is people will see you walking through the hall with craft supplies and they're like, 'Oh, your job's so fun,' but they don't know you're going to go help a child write their living will." So there's a lack of recognition for the emotional labor that the work involves, especially for some of the allied health professionals we've spoken with. And a quote from a respiratory therapist where they say, "Nobody knows what an RT has to do. Nobody knows that you're in the personal space of a family when their child is dying and the impact it has on us." This RT also expanded on this feeling of invisibility, despite having this very central role in the child's care and end-of-life care in particular. Their role didn't have the brand recognition of nursing or doctors. So when families would write in with thank you notes for the team, the interviewee felt that RTs were rarely mentioned. And they didn't blame the families for this, but they spoke instead to this broader invisibility they experience for a very important and impactful aspect of their work. Next, I want to highlight some of the external factors that impact people's emotion management at work. So first, from a respiratory therapist, they say, they would tell you that it's okay to be however you're going to be or feel however you're going to feel. But practically, no. Practically, there's one of me, and I'm running an ICU. That's the part that's hard, the part where the pace of the work does not allow for any buffer space. So even if there's a culture of openness in the unit, sometimes external factors and the practicality can run up against that. This is backed up by a child life specialist saying there's a really big part of the expectation where, there's another kid, there's other kids to be seen, and there's an expectation to really bounce your emotions for whatever the next family needs. And that's within minutes sometimes. Another external factor or more structural factor at play that can influence this idea of not having enough time or enough space is staffing and workload. From a respiratory therapist, we hear part and parcel of the resources for mental health support include not being overworked. And from a physician, we hear about some of the pressure and stress of more systemic failures or issues that are beyond the clinician's individual control. They say, the biggest and most frustrating deaths that have led to the greatest burden on individuals tend to be those where there may have been some modifiable issue in the system they're in. And that's where that frustration emerges. And that's where that guilt emerges. And finally, on a more positive note, I wanted to highlight the role of team relationships and how people make sense of death and dying at work from what we've heard so far. So first, we have a respiratory therapist sharing, I can tell a trainee it's okay to talk about your feelings. It doesn't make it true. They're going to learn that it's true and safe, not just by someone telling them, but by observing other people share and have it be safe. It's about the behaviors that everyone else is engaging in. And so then working very hard to ensure that we're all in a place where we can trust each other and that it's a safe space. And we have a physician sharing the importance for them of finding a close network of providers in the same sort of space that you are in, who can get it and understand exactly where you're coming from and talking about. And bringing these two pieces together, a nurse shares, my team at work is probably my lifeline. They're the most constantly positive thing that I can lean on and that I'm a witness to every day at work. So I think it's my most important tool when it comes to going through anything that's difficult and emotionally taxing. And now I'll pass it back to Lisa.
So our main goal is helping the PICU staff population, which will benefit patients and the Canadian healthcare system as a whole. Specifically, the way we're hoping to disseminate our results is to publish our findings, present them at CCCTG meetings or elsewhere, and then potentially use them to develop some supportive resources for HR or occupational health personnel at Canadian hospitals, depending on what specific findings and whether they're relevant to these groups. We think this is important as the study has the potential to inform training for future PICU healthcare professionals during the onboarding process, particularly given some of the concerns expressed by our respondents for newer colleagues and trainees. I'd also like to mention, if you would like to be added to a knowledge translation list to receive a copy of the published results, please talk to one of us or email Molly at IWK, or you could directly message me through this meeting chat if you'd prefer and give me your email. We'd just like to thank you very much for your time. If you have any questions, please put up your hand and we can answer those.
Amazing talk, and it's such important research. As someone who's actually worked in pediatric intensive care, it's so relevant, and some of your preliminary results I don't find surprising at all. Just like to open it up to anyone in the audience. We have about 5 minutes for questions, and if there's anyone who has any questions. Maybe I'll ask one while people are waiting. I was really interested in how you chose, just from the very beginning, like sort of how you chose which participants you would focus on. And so I noticed it was full time, and yet we know that, well, I guess having full time, it's easier when you do a online survey, but there's a lot of, especially older or more experienced people who've come back, especially with the COVID-19 pandemic, who are working in potentially part-time or even in a role. So that, and then also around, I would anticipate CHIO, sort of the bilingual aspect of only English speaking. So wondering about French.
To both of those. So in terms of full-time, we originally chose that to just make sure people would have enough experience to talk to primarily. And we did relax that for at least one interviewee recently, taking into account that they have more years of experience to kind of balance it out. But we would be more hesitant to recruit someone in that first 2 years or few years who's not full-time. But that was the general idea with that. And in terms of French, since the analysis team is Anglophone, having all those transcripts in English is helpful, but I'm bilingual. So as long as someone is comfortable doing the interview in English, we just had a Francophone participant where if they were looking for a word, they could say it and we could chat about that, while the bulk of the interview would still be all in English, but there'd be the chance to not hopefully miss too much nuance.
Great. Yeah, thank you. Any questions from our audience? Just look to see, maybe make sure I'm not missing people with their hands up. Yeah, so your thoughts around the respiratory therapy group. Again, not surprising because they would be certainly, if there's any withdrawal of care, always a very central group. I wonder sometimes whether it may reflect their education, in that certainly medicine, nursing do spend a considerable amount of time on end of life, palliation, care, self care. Was there any discussion around sort of their pre-licensure or education of whether or not that helps them cope, or whether that's something the employer should really ensure that all people working in pediatric intensive care receive?
In our interview guide, we do have a section about that education and any formal or informal training people are coming with. And the general consensus, regardless of profession, tends to be never enough, or not really any formal preparation for, especially the emotional sides of things, that it either gets very medicalized, and the important piece of learning how to do the medical side of end-of-life care, but there's an interest in more of those emotional aspects. Or we've had a few people talk about wanting essentially simulation labs or sim experiences for some of those difficult conversations you might have with or around families, from all the groups.
And maybe I missed it, but was there discussion around what would help around, so for example, debriefing with team after? Um, was there any discussion about that?
It definitely, and maybe to give Eva and Lisa a chance, maybe do one of you want to speak to either of those? I know you've been in the data recently.
Yeah, just I've only gone through a few of the transcripts, but team relationship and the debriefing component is a huge part of what a lot of the interviewees have noted to be, I quote, life-saving for them, where this is their team that they can trust, and this is the team that they can talk to, who understand what they've gone through. So that has come out and been highlighted as well. So I'm excited to deep dive more and get new information as we go through more transcripts and interviews.
Great. Well, again, thank you so much, Molly, Lisa, and Eva, for sharing your work. We'll look forward to seeing the final. And I have to say, it was really interesting to also hear about your program in which the research coordinators lead this work. It's really exciting and so relevant. So thank you again for joining us, and come back when you have your final results. We'd love to have you share with us.
Thank you.
Great.
Thank you. Take care. Bye.
So our next speaker is Neda Nassaji, and as I mentioned earlier at the beginning, is a first-year PhD student, and just absolutely thrilled to have her here today to learn more about her work. And so welcome, Neda. Take us away.
Thank you very much. Hello, everybody. Can you hear me, Marsha?
Yes, perfect.
Yes. And can I share my screen?
Yes, please do. And I'll let you know when it's viewing properly.
Yeah. Can you see my slides?
Yes, beautiful.
Okay.
Thank you.
Thank you very much. Can I start?
Yes, please.
Thank you very much. Hello, everybody. My name is Neda, and I am an international student from Iran. And I'm very, very happy being here presenting my research proposal related to my dissertation, PhD dissertation, titled Exploring the Health Needs of Immigrant Women in the Postpartum Period, a Feminist Post-Structuralist Study. And my supervisors are Dr. Megan Ashland and Dr. Jean Hughes. For this presentation, I'm going to focus on 6 different sections: an introduction, literature review, research design, ethical consideration, knowledge translation, and references. And as introduction, as you know, the physical and psychological health needs of immigrant women are considered a public health priority in many countries because immigration can exacerbate the health inequities. And currently, due to political oppression, due to war and poverty, immigration has increased globally around the world. Data from National Health Survey shows that Canada is a country with a great number of immigrant people, women who are in reproductive age, pregnant, or in postpartum period, make up a significant portion of immigrant population. And it has been proven that immigrant women are at a greater risk for adverse health consequences during pregnancy, childbirth, and the postpartum period compared to non-immigrant women. Examples of these consequences are preterm birth and abortion. To promote maternal health, some previous research studies tried to explore the specific needs, such as need for financial support of immigrant mother in the postpartum period, but other needs may exist. Moreover, immigration is a gender-based process. It means it can influence of men and women differently. For example, gender stereotypes affect women's self-governance and decision-making process, thus increase the possibility of systematic violation of human rights. Second, immigrant women have their own cultural beliefs, values, and practices that are different from beliefs and practices of people from North America. Higginbotham and her colleagues wrote, unfortunately, the needs and rights of immigrant women are often marginalized by cultural practices within family and communities and sometimes by legislation. Additionally, immigrants are sometimes exposed to discrimination related to their race or ethnicity, affecting their access to healthcare services. Extensive literature exists on the under or overuse of healthcare services by immigrant mothers, but our knowledge about the health needs of postpartum immigrant women in a socio-cultural context is very limited. Understanding the health needs of postpartum immigrant women is important because it can help us to support them in the best way possible. Therefore, this research study aims to explore the health needs of immigrant women during the postpartum period. And as my research question will be, how do immigrant women experience their postpartum health needs in Halifax? To find the relevant literature, I will search the following databases: PubMed, Biomed Central, CINAHL, Google Scholar, and some non-Western databases. I will use key terms: postpartum, health needs, immigrant women, feminist post-structuralisms, and gender. I have focused the literature review, or divided the literature review into 3 different areas: gender and health inequality due to migration, barriers to postpartum health of immigrant women, and cultural differences. And as you know, women migrate due to different reasons such as poverty and climate changes, climate disaster. Although these women can enter the workplace and contribute significantly to economic development, migration can lead to gender inequalities such as lack of access to resources, and migration can also lead to health inequalities. For example, immigrant women have proper health and demonstrate and their use of healthcare services, especially after childbirth, compared to non-immigrant women. I'm sorry. A research study conducted by Suer and her colleagues ascertained that compared to non-immigrant women, immigrant women had lesser household income, lesser social support, postpartum psychological issues, and learning needs that were not met in clinical settings. And a barrier to postpartum health of immigrant women, I would like to say that several factors have crucial roles in the health of immigrant women during the postpartum period. Suer and her colleagues believe that culture, language, and socioeconomic factors play an important role in shaping the postpartum experience of immigrant women. Providing care for immigrant women is often challenging due to language barrier and specific values that influence the delivery of healthcare to immigrant mothers. And in terms of cultural differences, I would like to say that the cultural beliefs and values sometimes prevent immigrant women from engaging in activities that promote their health after childbirth. For example, mothers from some cultures do not like to report their reproductive issues because they believe that reproductive issues are a result of unethical behavior, or they sometimes are considered normal aspect of pregnancy and childbirth. And in terms of methodology, feminist post-structuralisms will be applied as a methodology in this research study. It provides a lens through which the role of gender, sexuality, class, race, ability, knowledge, and relation of power can be explored. These concepts provide an important base to challenge, test, and deconstruct patriarchal discourse, social institutions, and power relations that oppress women. And as you know, the important concept of FPS, according to Ashton 2016, including power as relational, binary opposites, regulated communication, feminist theory, language, discourse, subjectivity, beliefs, values, and practices, and subjectivity and agency. This research methodology can help me to understand, for example, what are beliefs, values, and practices of immigrant women? How do immigrant women negotiate power in the postpartum period? How do immigrant women position themselves as mothers, immigrants, and etc.? How do immigrant women affect by personal, institutional, and social discourses? And because my aim is to deep understanding of the health needs of immigrant women, a qualitative research approach will be selected using, guided by feminist post-structuralisms. I will apply a purposive sampling strategy. 12 to 18 immigrant women will be chosen to participate in this research study. Participants must be at least 19 years old. They must also live in Halifax and be in the postpartum period up to 12 months after giving birth. They should have come to Canada as immigrant anytime within the past years, and they should identify themselves as female. Regarding the recruiting strategy, and electronic poster advertising will be utilized. Data will be collected through semi-structured interviews. All interviews will be conducted face-to-face and audio tape recorded. All interviews will last about 45 to 60 minutes. All research material will be stored electronically on the Dalhousie University internal OneDrive. And for data analysis, a feminist post-structuralism discourse analysis will be used. Ashton Open Guide will be applied. First, issues should be identified, then beliefs, values, and practices, and then discourses, relation of power, agency, and subjectivity will be recognized. And in terms of trustworthiness, my supervisors and I will collaborate on the analysis of the data. I will record all the events that will take places, giving this study more credibility. Dependability will be achieved through detailed documentation of the research process. Thick description will be used as a transferability method. And in terms of ethical considerations, this research study will be approved by Dalhousie University Ethical Committee Board before the study begins. All participants will sign an informed consent form prior to study. Before the interview, a complete explanation regarding the study will be given to the participants. The mothers have the right to withdraw from the study whenever they wish up to 1 week after the interview. And in terms of knowledge translation, educational workshop will be held for immigrant families to inform them about the research results and available resources that postpartum immigrant mother can use. A special pamphlet will be designed regarding the research results, and they will be given to immigrant women. Moreover, giving speeches at conferences, updated websites, and publishing scholarly articles will help healthcare professionals and decision makers to be informed about the health needs of immigrant women. I would like to say that for this research study, I'm going to work closely with ISAN Center, and I believe that this can help me to become familiar with immigrant population and the real health needs of this group of people. And here are my references.
Such an amazing and such an important topic. Fantastic, Neda. I think for so many of us who work increasingly with women who have been recently come to our country, this work will be so important. Is there anyone in the audience who have questions for Neda?
Can I stop sharing?
Sure.
Thank
you. Yes, Morgan.
Yeah, first of all, great job, Neda. I love listening to my fellow classmates present their research aspirations. It's always super exciting to hear how productive everyone is. So great job. The question I have is just for your consideration. It's just one that popped into my head, and it's completely okay if you aren't interested in doing this or if you just haven't considered it. But I work in a rural hospital in Truro, and I know we have a high percentage of immigrant women on our postpartum unit and just immigrant families on acute medicine on any unit that we have in the hospital. So I wondered if you were interested at all in the perspectives of immigrant women on postpartum units in more rural areas of Nova Scotia, because I know you mentioned that you would be exploring the perspectives solely of women on the postpartum unit in Halifax, because I imagine that the perspectives would be completely different in terms of access to care and just their entire way of living. So is that something that you've considered? I know that would make your project a lot bigger and more convoluted,
Yes.
but yeah.
Yes. Do you mean that it's better that I expand the research setting in the whole Nova Scotia instead of Halifax?
I wouldn't say that I think it's better because I don't have experience in your area of expertise conducting this type of research, but it was just a thought that I had on whether or not you think that the perspectives would be different if you did explore rural perspectives.
Yes, sure. It's very, very better. I think so. I agree with you. And as you know, for my master thesis, I work on whole Nova Scotia, not just for Halifax, because my interview was online interview, and it was possible. But in terms of in face-to-face interview, I think it's a bit challenging.
For sure.
Yeah,
well,
challenging. But it's a very yes. But I agree. It's a very, very interesting comment. Suggestion.
I didn't realize that for your master's you had the opportunity to do the online interviews to connect with a wider variety of people. So that's great that you were able to obtain those perspectives. So great job.
Yeah. Thank you. I will think about that. It's a great idea.
Any other questions for Neda? So Neda, while people are thinking, I actually I'm just going to build a little bit on a bit where Morgan was discussing, in that it's sort of how you were going to recruit and whether or not you had were going to just do solely in person or consider using an online like you had used previously. Not just for your work, but just your thoughts given a post-pandemic research field that we're now working in the expectations of whether people will prefer or not prefer in person versus online.
Yes, for my master thesis, I used virtual interview, remotely interview, and all participants would like to participate by phone, surprisingly by phone. And by phone interview had some limitation. For example, we didn't have eye contact, or I didn't see the body language of the participants. So for these limitations, for my PhD dissertation, I decided to use the face-to-face or in-person interview, and I think maybe it doesn't have the some limitations that online interview have. It's an initial thought.
So interesting, Neda, that because interestingly, even with phone, there would be potential for FaceTime, but I guess it depends on what type of electronic device and whether or not, for instance, we know that where you live and your socioeconomic status certainly makes a difference with your ability to access computer, less so for smartphone, but certainly for computer. And so, working. And have you asked immigrant women, sort of if they had a preference, what they would like? Like, do you have someone who you work with on your team to sort of think about those perspectives?
No, I didn't ask from immigrant women, But for my master thesis, I asked from my participants. I had this opportunity to my participants to choose which way, for example, which route of interview did they preference, for example, by phone or online platform, and all of them, surprisingly, all of them chose the phone, by phone. And I don't know why they prefer to interview by phone.
Interesting. That would make
Yes.
for a very interesting research project in itself, right? How do we reach families, women and families who are coming to us? How do we best reach these families to be able to get information to try to help them navigate and have better the healthcare system and better outcomes? That's interesting. And is there any other questions or comments from the audience before we finish up? How are you, Neda, going to find the women?
Recruiting, as recruiting strategy, I'm going to use an electronic poster advertising, and I'm going to post it to social media, such as the website, my supervisor websites, and some social media that connected to this website, such as Twitter or Instagram, for example. And I'm going to work closely with ISAN Center, and in ISAN Center as well, I think I can get familiar with families, with women, and I can participate, for example.
Yeah, I think it's so important to have those close connections with safe places that these families go, because we know that there's a wide variability of who's actually on social media and who has access. So working with obstetricians or family doctors who have large, perhaps in areas where they have immigrant women in their practice. And so when they come for their prenatal, to sort of engage them with posters and advertisement or at the centers, I think is an excellent way. And with respect to Morgan's comment, even if you only affiliate it with one or two places in the province, might be really interested to get a difference. I would anticipate there is a broad difference in rural and urban perceived supports and available supports.
Okay. I will think about it. I will think. It's a great recommendation.
And or your postdoc or your next project after PhD. So many questions to be answered. Any other questions or comments from the audience? Well, if seeing none, I just want to thank you so much again to our first speakers for their wonderful presentation and work. And for you, Neda, good luck to all of you. Thank you so much for taking your time to present to us today. Thank you for everyone who joined. And everyone have a great day.
Thank you.